Good morning, everyone, or good evening, everyone, and welcome to today's webcast of Women and Psoriasis. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You join the presentation listening using your computer's speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you would prefer to join over the telephone, just select Use Telephone in the audio pane, and the dial-in information will be displayed. You will have an opportunity to submit text questions to today's presenter by typing into the questions pane on your control panel. You may send the questions at any time during the presentation. We will collect these and address as many as possible at the end. And before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice of millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. One way we improve the lives of those living with psoriatic disease is by offering a patient navigation center. Whether you've been newly diagnosed or have lived with your condition for years, our team of experts can help you find healthcare providers, discuss treatments, and get help with insurance. We'll work with you one-on-one to provide support in your journey towards a healthier life. And in order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. If you'd like more information on how to become more involved with the Foundation, you can visit us at psoriasis.org/get-involved. Next, on behalf of the National Psoriasis Foundation, we want to extend our thanks to Taro Pharma for their sponsorship of today's educational webcast and for making this presentation possible. Now I would like to introduce our guest speaker, Dr. Jennifer Song. Dr. Song is a board-certified dermatologist currently practicing at Southern California Dermatology in Santa Ana, California. Dr. Song has a broad interest in medical and cosmetic dermatology as well as clinical research. Dr. Song is an expert in psoriasis treatment and has extensive experience using phototherapy, systemic medications, and biologics in the treatment of psoriasis. She has authored several peer-reviewed journal articles and lectured at professional meetings to talk about new advances in the treatment of psoriasis. She has served on the UCI School of Medicine faculty as an assistant professor of dermatology and the director of dermatology clinical research from 2010 until 2015. She also serves on several advisory boards and is a consultant for the pharmaceutical industry. She is currently a President's Council member with the National Psoriasis Foundation and a fellow of the American Academy of Dermatology. We are very excited to have you, Dr. Song.
Thank you so much for your introduction. I always like to start off telling the audience a little bit more about myself, and it's a little bit harder in a webinar because you don't get to see my face. You see my picture, but we don't get to engage directly with each other. So my interest in psoriasis grew actually when I was in medical school. So that was over 10 years ago. And I was very interested in the immunology of psoriasis. And that was when one of the first biologics came to the market to treat patients with psoriasis. And that really, I would say revolutionized the way a lot of psoriasis patients are treated and also the way we see psoriasis. We now know that it's really considered an autoimmune disease where certain type of inflammatory cells are overactive and secrete a lot of inflammatory proteins, which then result in a psoriasis plaque. And at that time, the first biologic was in fact named Amiviv, which is no longer available, but I was studying it and it only worked in about 25% of patients. So really we've come a long way in terms of the many different treatments available for psoriasis patients. And I was looking at different markers, genetic markers, to predict how patients would respond. And at that time, I was studying in New York and really with a world-renowned expert in psoriasis, and that's where my career in psoriasis began. And that was also where I met my first patients, and those patients really remain gave me a really strong impression of what it was like to have psoriasis, and really made me want to treat a disease that I feel like not a lot of dermatologists are familiar or comfortable with a lot of the newer treatments. And at that time, there were many clinical trials ongoing for a lot of the biologics you might be familiar with that are already on the market, like Enbrel and Humira. And I remember how patients had told me when they had first come in how it affected everything that they did, from waking up in the morning and deciding what they were going to wear to even affecting their livelihood. Like, they could not find a job because most people didn't know what was on their skin, and most people would assume that it was infectious. And so when they eventually had clear skin, that was something that they found. Not only were they appreciative, but that really, to say the least, changed their lives. So ever since then, I have had an interest in treating psoriasis patients, as well as doing a lot of clinical research. And so it's my pleasure to be here today to talk more about psoriasis, and in particular, women in psoriasis. So here's an outline of today's presentation. We're going to be talking about treatments. We'll also be talking about diet and exercise. There's no doubt that there's a lot of emotional and psychological impacts that patients experience with psoriasis. We'll also be talking about relations and intimacy, and then concluding with unique issues that women find relating to conception, pregnancy, and nursing. So starting off, like I said initially, psoriasis is now considered an autoimmune disease, and unfortunately there is no cure, but and it is a chronic disease, but there's lots of different treatments now available for patients to help control the disease. It affects 7.5 million Americans, and that's about the population of New York City, and half of those with the disease are women. And women do face unique issues when deciding on treatment because of family planning, as well as taking into consideration clothing and what they're going to wear, as well as beauty products. So here are the different treatment options, and this is how, when I try to explain it briefly to patients, the different large categories of treatment. So here we have topical treatments. So this is creams, ointments, lotions, anything that you apply to the skin. Then we have phototherapy, which is a form of light therapy that we've used in dermatology for over 100 years in treating many, many different skin diseases, but most commonly psoriasis. And then we have systemics, which are pills that you take to help control the inflammation. And then biologics, which were invented in the last 20 years, which are injectables, either given as a shot or an infusion to decrease the inflammation in psoriasis. I think it skipped one slide quickly over, so let me just go back one. Okay, great. So the next slide focuses on topical treatments. And so, like I said, these are applied to the skin. And these are often the first treatment we try when a patient is diagnosed with psoriasis. And some topicals can be purchased over the counter, and a lot of them are available by prescription. So certain considerations for women is that it's easy to use. Other things that we think about is, is it compatible with other beauty products? So I often ask patients, the most common type of topical prescription treatments come in different formulations. So it could be a lotion, an ointment, which is greasy like Vaseline. or a cream. And I often ask the patient what their preference is, because if you don't like the way the cream feels on your skin, then it's going to be hard to use. Ointments often can be more effective to help with the psoriasis, but they're really greasy. So if they're like, because it's like Vaseline, then it can be messy on your clothing, and that might not be easy to use. Might be at night, but during the day when you're getting ready to go to work or you're going out, that's not going to be fun to use. So a cream might be better for the day. Also, it depends on the area of the body that it's being applied to. So foams might be easier for the scalp, as well as liquids, and not the creams and the ointments. So I think it's important to ask the patient their preference, because that's what they're going to be applying to their skin, and you have to like the way it feels on your skin. There's also different types of oils too, medicines that come in different oils. Going on next to phototherapy, that's light therapy, so that involves exposing the skin to certain wavelengths of ultraviolet light on a regular basis. And this is done under medical supervision, so it can be done in your doctor's office or a psoriasis clinic, and even some patients or insurances can cover a phototherapy unit so that you can do the treatments at home. So an analogy is that it's like a tanning booth, but safer. And so you're using light, ultraviolet light, to decrease the inflammation of psoriasis in the skin, and that's how it helps the skin heal. So certain considerations for women include, when they're doing light therapy, is if there's going to be hyperpigmentation, so are they going to get more tan, or maybe hypopigmentation, so discoloration in the skin. There are certain types of light therapy like PUVA where you take an oral medication before going into the light booth, and that kind of helps the skin improve faster, and that can often give you a lot of sunspots. I think the hardest thing that a lot of patients find for doing phototherapy, although it's very safe, is the inconvenience of it, because oftentimes you're going to a clinic or a doctor's office, and that can be very challenging in everyone's busy work life as well as family life to find the time to go to the clinic on a regular basis. And that's usually 2 to 3 times a week when you're trying to clear your skin. So the next category are systemics, and these are prescription medications that are taken orally and work throughout the body. They're usually used for patients who have moderate to severe psoriasis and psoriatic arthritis. And certain considerations for women include whether they're planning a family, whether they're actively or currently pregnant, and then, of course, breastfeeding. So these 3 topics we're going to talk about in more detail, but these are definitely considerations before starting any sort of oral medication. The next category are biologics, and so these are usually prescribed, again, for moderate to severe psoriasis that hasn't responded to other treatments. And these are often given by an injection or IV infusion. So again, the same kind of considerations for women apply. And of course, you have to be okay with the needle since they're injections or getting an IV infusion. So diet and exercise. I think that having psoriasis and psoriatic arthritis raises your risk of developing other conditions, and these are called comorbidities. So we know that psoriasis patients have higher risk of heart disease, tend to be overweight, have diabetes, and high blood pressure. And so patients ask me, well, Dr. Song, is there a certain type of diet I should follow? And I tell them that sticking to a healthy diet and a regular exercise routine can help you reduce the risks of these other comorbidities. It's not going to cure your psoriasis, but having a healthy diet and exercising regularly will keep your weight down and improve your overall health so that it can help your psoriasis. So other diet tips. Because psoriasis is an inflammatory disease, adopting an anti-inflammatory diet can help reduce the symptoms. So these include eating fish, experimenting with removing gluten. So I think that we say experimenting with removing gluten because some patients may don't necessarily have a true gluten allergy, but may have a gluten tolerance. And this is something you would need to explore with your dermatologist, because a true gluten allergy is a disease called celiac disease, and there are certain blood tests that we can do to check for that. But in psoriasis, the connection is not so direct. But if you have a gluten intolerance, that removing gluten if that improves your psoriasis, that's something that you can try. Cutting out sugar, using nut oils, also using an inflammatory combating spices like turmeric, limiting alcohol, and also taking probiotics, and eating a rainbow of fruits and vegetables. And these diet tips are applicable to anyone who wants to lead a healthy diet, not just necessarily because that you have a autoimmune skin disease. And keep in mind that no treatment works for everyone, and the same goes for dietary changes. So there is some scientific evidence that making these changes to your diet can improve your health and reduce the risk of developing the comorbidities like the heart disease and diabetes. And that's the most important point I'd like to stress here, is that really we do know that psoriasis patients have higher risk for heart attack and diabetes. And so any sort of lifestyle changes and dietary changes that you can make to decrease your risk for specifically the heart disease and diabetes is going to go a long way in terms of also improving your psoriasis and leading a healthy life. Okay, so for exercise tips, I always tell patients you don't have to suddenly go out and start running a marathon, but really start small. So walking in 10-minute increments and building up from there. You don't have to overexert yourself, so working your muscles too hard can lead to more inflammation and pain. Do something you enjoy. I think that's really important, so that you stay interested and want to continue doing that. It's really a lifestyle change. Stay hydrated. You want to avoid exercising in high temperatures. Also trying gentle yoga, and this can really enhance your mobility for psoriatic arthritis. The National Psoriasis Foundation, in fact, recommends that you check with your doctor before beginning any new diet or exercise program. And I think just like diet changes, exercise as well, you start small and you try to implement these changes into your daily life so that it's going to be a long-lasting lifestyle change. So there's no doubt that there is a significant emotional impact that psoriasis has on patients, and we know that people with psoriasis are twice as likely to become depressed as the rest of the population, and those with psoriatic arthritis have an even greater risk. A recent NPF report showed that 20% of women felt that psoriasis was a very large problem in their lives compared to 12% in men, and 60% of women said psoriasis interfered with their capacity to enjoy life. So we're going to explore this a little bit more. And for those of you who have psoriasis or know someone who does, you know how that can impact their lives. From the first thing you wake up in the morning, you have to decide on what to wear. I think you've already been made aware of your psoriasis, because you're going to think about, well, if I have patches and plaques on my elbows, I have to wear long sleeves to cover it, or if you have scaling in your scalp, and you would tend to avoid wearing darker colors because you don't want other people to see the flaking. So I think that it starts, it's something that no doubt patients are constantly having to think about their skin. And so, and this definitely brings stress on life. And so that brings us to the next slide, the stress cycle. There's growing evidence that indicates that the same process that triggers the inflammation in psoriatic disease can also create changes in the brain that affect emotional states. So stress is hard to measure, but there's no doubt that stress can trigger inflammation and then eventually worsen the psoriasis and result in a flare. So looking at the emotional side of psoriasis, here is a congressional briefing with Cyndi Lauper, and this was on April 19th, where Cyndi Lauper was present at Capitol Hill for a congressional meeting, and the purpose was to call attention to the connection between psoriasis and the mental and emotional health. And the goal is to discuss the importance of more treatments and improved access for patients. So how do we manage the emotional impact? Well, we discussed the different treatment options. So in fact, TNF blocking agents, these are a specific type of injectable medicines for psoriasis, have shown that blocking TNF can disrupt certain signaling proteins like serotonin in the brain. And this can ultimately help with the emotional impact of psoriasis. There are also antidepressants, anti-anxiety medications. Meditation is also very helpful, as well as behavioral therapy. So I think, if this is something that you want to explore more, definitely ask your doctors. Don't be afraid to ask your doctors about it. Another area where psoriasis impacts patients and is often not discussed is relationships and intimacy. So when patients come to see me, I always ask about, like, do you have psoriasis in your genital area, or do you have psoriasis down there? Patients kind of are often embarrassed and don't want to talk about it. In fact, a third of people with psoriasis and psoriatic arthritis say that the disease interferes with their love life. And so it's really important to establish a supportive and trusting relationship with the other person, and understand that there may have to be modifications to intimate activities when a person's having a flare or when they're having active lesions in the genital area. I have another story that really remains in my memory from when I was at UC Irvine. I had a lot of international patients who came to see me at the academic center, and one in particular, it was a female who came from the Middle East. She came from Dubai, and when she had come to see me, she said, I came all the way from Dubai to come to see you because, one, many of the doctors, I can't show the doctors in my country my rash down there. I said, okay. And she was dressed in her traditional garb. She actually didn't change into like a gown and so when she showed me her genital area, she was so embarrassed for so many years and not comfortable because of her religion and her gender, and show any doctor in her country that she in fact had genital psoriasis, and so was never properly treated. That example remains in my memory because I think it makes it very difficult to share with the doctor, and I think that there are multiple issues, not just cultural, but as well as and religious, but also gender issues. In fact, it may be hard to find certain beauty products, or this is an issue unique to women. So especially in the beginning of a relationship, some women feel more comfortable covering up their psoriasis. So finding the right product can be hard. So you often have to go to a specialty makeup store where you can try different options and find makeups that are often thicker to be able to cover up the psoriasis. You choose products that are designed for sensitive skin, so oftentimes without perfumes because that might irritate the psoriasis. And you look for cosmetics that are compatible with your topicals and other moisturizers, or with your topical medications. Clothing choices. I think nearly half of women surveyed said they alter their clothing choices to conceal psoriasis, compared with a third of men. So choosing clothes that feel comfortable and make you feel confident is important. Washing new clothes before wearing them to remove any chemicals that might irritate or exacerbate your psoriasis. Using mild detergents is important. Keeping garments loose to avoid irritation in the skin so that doesn't exacerbate the psoriasis, are all things that women think about when women who have psoriasis think about when they're getting ready for their day. And when you're ready, be open about your condition with your partner. So other tips for managing psoriasis in intimate relationships is that definitely let your partner know that psoriasis is not contagious. So I think that's often the most common question any patient who is newly diagnosed asks me, is this contagious, or did I get it from someone? And then reassuring those people who are close to you that it is not. Don't apply any high concentration coal tar ointments. Coal tar ointments are an old treatment to sensitive areas like your genital area, to the penis, scrotum, or vulva, or to any cracked skin, because this can cause more irritation. Using mild cleansers without scrubs or perfumes, and cleaning the area and reapplying medications after being intimate. Men may find it helpful to wear a lubricated condom during intercourse. I tell men all the time lubrication is very important, and because this can, more rubbing or friction on the skin can actually trigger more psoriasis. And so the lubrication can keep the skin from becoming more inflamed. Because unfortunately, psoriasis can happen anywhere on the skin. It can happen in the genital area. It's much less common on the face, but it can still happen on the face. So going further into genital psoriasis, the most common type of psoriasis in the genital area is called inverse, where it occurs in the fold area. So here you see a picture. This looks like the gluteal fold, or the fold in our buttock area. That's a classic area where psoriasis can start, and it usually appears much more smooth and dry, but it's definitely bright red. It can occur even on the upper thighs, in the creases between the thigh and the groin, near the anus, in the pubic area, as well as the genital area themselves. Okay. And so I always ask my patients about if they have any psoriasis in sensitive areas like this, because a lot of times it might not appear to be so obvious that it is psoriasis. Okay, so more tips in managing genital psoriasis. Acknowledge how the genital psoriasis affects your daily activities and make sure your partner is aware of it. Understand that it generally does not cause sexual dysfunction. So using treatments like corticosteroids is exactly prescribed, because these are considered sensitive areas, so we don't want to overuse topical steroids. When we overuse topical steroids in sensitive areas like the genital area or any fold area of the skin, this is where you can get side effects from steroids. You also want to protect the area from friction injury, so using good toilet paper, wearing loose-fitting clothing, as well as applying mild lubricants. Okay, and so what I was talking about earlier, where I said, friction can trigger a new psoriasis plaque, this is called the Kebner phenomenon. So psoriasis can appear in areas of the skin that have been injured or traumatized, and this can include something quite as simple as just a scratch, or even a sunburn can trigger psoriasis, as well as any friction. So psoriasis plaques due to the Kebner phenomenon are believed to affect up to half of people with psoriasis. So even maybe a minor surgery scar or can actually trigger a new psoriasis lesion. And some people will develop a new lesion every time their skin is injured. So you can see in the picture, this patient looks like maybe they had scratched their skin on something, and that formed a perfect linear psoriasis plaque. So in particular, treatments for this area, because genital skin is thin, many topicals used for other parts of the body are not options. So good options include low-strength steroids, and your dermatologist will tell you how exactly to apply them and how often. Vitamin D derivatives are good because these are non-steroids. Using natural oils are a good option. as well as looking further into other treatments like oral treatments, pills, or injectables. So always be honest and open with your doctor about your genital psoriasis, and let them know how it interferes or affects your life. And that's the most important question I ask patients is, how does the psoriasis impact your life? And that really dictates how aggressive, or how what treatments we're going to be talking about. So this is an issue specifically unique to women, so conception, pregnancy, and nursing. And so there are many things to consider when deciding to have children, but when you have psoriasis, you have some more decisions that may be more complicated. And so thinking about the genetics of psoriasis, what your different treatment options are, as well as disease management. So in the following slide, we're going to talk a little bit more about the genetics. So many women worry about passing psoriasis to their children. And it is believed to be a genetic disease. So in fact, we call it a complex genetic disease because there are genetic factors, and it's not the genetics alone, as well as probably something environmental that triggers or brings out the psoriasis. And so researchers do not completely understand how psoriasis passed from one generation to another, but we've seen certain patterns in studies. So if one parent has psoriasis, a child has about a 10% chance of having psoriasis. So oftentimes I see a patient, they're like, Dr. Song, I have no idea where my psoriasis comes from. Nobody in my family has psoriasis. So this is that situation where one parent, if one parent has psoriasis, a child has about a 10% chance of having psoriasis. If both parents have psoriasis, a child has a 50% chance of being diagnosed with the disease. And about 1 out of 3 people with psoriasis report that they have a relative who has or had psoriasis. So there's a genetic component, but it's not the whole story. Other considerations for starting a family. So when pregnancies are planned, women may want to time treatment, so only minimal treatment is required during pregnancy. And I'm very much of a believer of that. I have 3 kids, so I think that I'm very conservative when it comes to pregnancy, because the last thing I would want is for something to happen to the baby and that it could have possibly been related to a treatment related to the psoriasis. So in general, most systemic medication should be stopped before trying to conceive, and this is an absolute must with methotrexate. So methotrexate should be discontinued in men and women for at least 3 months before trying to conceive. Women who are taking another medicine, oral medicine for psoriasis called Soriatane, must use reliable methods of birth control and wait 3 years after discontinuing the medicine to become pregnant. So in fact, in my practice, I don't use Soriatane at all in any woman who's of childbearing age. Another medication called isotretinoin needs to be stopped 2 months before conception. So it's really important to share with your doctor if you're considering starting a family for women, because that is definitely going to alter your treatment options. Other considerations for during pregnancy is that the psoriasis can be unpredictable in pregnancy. Some women see an improvement in their psoriasis, while others report their psoriasis gets worse. So in fact, I usually recommend minimal or less treatment when women are pregnant, because the majority of women, so studies have shown, over 55% of women tend to get better during their pregnancy. About another 20% stay stable during their pregnancy, and maybe another quarter of patients can worsen. But because the majority either stay the same or get better, I think it's better to start with less than risking anything. So the NPF medical board recommends moisturizers and emollients to be used initially on psoriasis because there are no known adverse effects. So that's first line. So any moisturizers, and then just really next topical treatments. So after moisturizers and emollients, low to moderate dose topical steroids. And then if needed in the 2nd and 3rd trimesters, we can use slightly higher potency topical steroids. And because pregnancy is a predefined period of 9 months, I tell women that, you know, we don't want your psoriasis to flare or compromise your health or affect the baby. And so we start with the conservative approach of starting with moisturizers and emollients and then topicals. Other what we call category C topicals, meaning that these were not tested for safety in specifically in pregnant and nursing women, include the list that you see there. So Anthralin, Dovanex, Taclonex, and Vectical. And then light therapy is generally safe during pregnancy. So often like light therapy during pregnancy. One consideration is definitely sunscreen should be used to the face because you can get some sunspots as well as a condition called melasma where we get brown spots on the face, especially in pregnant women. And then systemic medications, generally speaking, should be avoided while pregnant or breastfeeding unless there's a clear medical need. So I definitely have some patients who get worse during pregnancy, and this is where your systemic or biologic medications come in handy. The systemic medications can be secreted in breast milk, so caution must be exercised. Cyclosporin, which is a very useful oral medication for psoriasis that can be used. Often I use it as a rescue medicine when the psoriasis flares. It should only be used if the benefits outweigh the risks. So there are risks of low birth weight and premature birth. We know that because this is the same medicine that is used in our transplant patients. And transplant patients are patients who've had liver or kidney transplant, and they need these organs. And so we have information from these patients who have to take the medicine and who've had pregnancies. So cyclosporin is a medicine that has been well studied. And there are situations when a psoriasis patient can have a really severe flare, even changing to erythrodermic psoriasis or even pustular psoriasis, where they get pustules on their skin. And that's a situation where it could endanger the mother's livelihood as well, and we would consider starting cyclosporin. There are studies of pregnant women treated with systemic steroids, and these have not found an increase in birth defects, despite animal studies saying that it may cause an increased incidence of birth defects like a cleft palate. Okay, and then biologics, like I said, are proteins that block specific inflammatory proteins that are elevated in the blood in psoriasis. The NPF medical board, in fact, suggests that TNF alpha inhibitors, a class that suppresses the immune system, may be used with caution in the second and third trimester. So specific strategies may be used to reduce the risk and exposure to your baby. And many of the pharmaceutical companies maintain registries to track pregnant women who are on the drug in order to better understand the effects of a particular biologic on the mother and the baby. So in fact, if you get pregnant while on a biologic, either you or your doctor can call the company and add your name and information to the database. So this is really valuable information because of ethical reasons, we can't do studies on women who are pregnant. And so getting more real-world information about these medicines and women who have been pregnant on it is very useful. And so you see the numbers there. And in fact, I do have patients who are pregnant, and because of a previous pregnancy, the patient knows that they have flared, and we've made a decision to proceed with continuing the biologic during their pregnancy. What to avoid. So these are clearly medicines that can cause birth defects. And so Tazorac is one of them, and this medication can cause fetal abnormalities. Definitely oral retinoids. These are, in fact, derivatives of vitamin A, and vitamin A is known to cause birth defects, as well as PUVA treatment, which is a form of light treatment where you take an oral medication before going into light treatment. And then after delivery, be sure to let your obstetrician know that you have psoriasis and psoriatic arthritis. In fact, this is actually the most common time that women report a flare. You just had a major stressful event, which is the delivery of a baby. On top of all you're fatigued and the emotional aspect of that, unfortunately, it's a common time for having a flare. Also because during your pregnancy, the majority of women tend to be stable or have improvement of their psoriasis. Your immune system actually changes when you're pregnant, and to help protect you and minimize infection. And in fact, that kind of pregnancy state is favorable to improving your psoriasis. So after you have the baby, your immune system kind of reverts to what its kind of normal state is, and so that unfortunately tends to make psoriasis or bring out psoriasis. You can definitely talk with your obstetrician if you have genital psoriasis and you're planning a vaginal delivery. Also talk to your doctor about any depression or depression symptoms you have after the delivery. So these include thoughts of hopelessness or harming yourself and the baby, guilt, anxiety, irritability, and inability to feel pleasure. So, these aren't just common to women who have psoriasis, but any woman who has a baby and that postpartum depression. So in conclusion, definitely find a doctor who you feel comfortable with talking to about these sensitive issues. Know the signs of anxiety or depression. Eat a healthy diet and exercise to help your disease. Be open and honest about your psoriasis with your loved ones as well as in your intimate relationships. And definitely review and talk to your doctor about the different treatment options. And don't feel like just because you have to, don't feel like you have to give up or breastfeeding or not have children because you need to, because of the medications you're on, because we have so many treatments now for psoriasis that you can definitely find one to make, to fit your needs. And remember that you're not alone. And I think that the National Psoriasis Foundation does an amazing job of helping patients connect to other patients, also to getting the resources that they need so that they can help themselves and find the right doctors so that they aren't alone.
Terrific. Thank you so much, Dr. Song. We're now going to dive into our question and answer portion of the webcast. And our first question here is, how does menopause affect psoriatic disease?
So I don't know of any particular studies that hormones specifically affect psoriasis. Patients always ask me, well, what's the course of my psoriasis? And we can't predict. It's different for every patient. So for some patients, as they get older, their psoriasis may be more quiet. Other patients, as they get older, it can become more active. And so that's the hard thing about psoriasis, is that we don't know what the natural course is. And so at this time, there's actually no research or no known relationship between hormones or specifically menopause and psoriasis.
Thank you. Along those same lines, we have a participant who wanted to know if methotrexate stops menstruation. She was taking the medication and her period stopped for 6 months. She thought she was going to menopause, but when she stopped taking the medicine, her period came back heavier than before.
Interesting. No, methotrexate specifically should not interfere with your menstrual cycle. It's interesting that when this patient says they were on it, it stopped and then it came right back as soon as you stopped the methotrexate. I would definitely encourage the patient to talk with their primary care doctor just to make sure there's no other issues that might be causing that change in your menstrual cycle. But that would be unusual side effect of the methotrexate.
Okay, great. We have another question here. This participant has nail psoriasis and wants to know if she can get manis and pedis.
Great, good question. So psoriasis itself shouldn't, prevent you from getting manicures and pedicures. I always tell patients to be careful getting manicures and pedicures just because even if you didn't have psoriasis, if they didn't clean their instruments well, you're just at risk for getting infections like toenail fungus or like fungus in the nails. But no, I actually encourage my psoriasis patients to get manicures and pedicures because there aren't a lot of good treatments for nail psoriasis, so they can help you trim your nails and make them look nice.
Yeah, wonderful. And we have a couple participants who want to know if psoriasis on the nipples what's the interaction with breastfeeding? Is it safe for the baby?
Great question. So breastfeeding itself, even without psoriasis, can be challenging. So I think that with psoriasis on the nipples, that can be more challenging. The psoriasis itself does not affect the baby. As long as the baby is able to latch on fine, then I don't see it as an issue. I think, again, lubrication is very important. So between feedings, you can also ask your lactation nurse too. Often, some lactation nurses don't like to use any emollients on the nipple. Vaseline to me is fine. And also some lactation nurses will encourage using the breast milk itself because it actually has a lot of anti-inflammatory properties and emollient properties, is to put some breast milk on the nipple after feeding. As long as the baby doesn't care and you're not having any pain or it's not exacerbating the psoriasis, there's no need or urgent need to kind of treat it right away. If women do prefer to treat, then I usually tell women to apply their medication, their topical steroid, and usually I use something no more than a medium strength topical steroid, but 2 hours before or 2 hours after nursing. And that can be really tough in the beginning when sometimes your baby's nursing like every 2 to 3 hours. So it has to be tailored to the individual patient. But using topicals is fine as long as it's not a high potency topical steroid, and like I said, 2 hours before, 2 hours after nursing.
Wonderful. We have quite a few questions on wanting to know if nightshades are okay or if they should be cut out when you have psoriasis.
Say that again, nightshades?
Yeah, so like nightshade vegetables, if you would recommend cutting those out.
Oh, I'm not familiar with the term like nightshade vegetables. Does that refer to a specific type of vegetable or?
Yeah, like peppers and tomatoes, eggplants.
Oh, okay, got it. Okay. I know there's lots of different kind of like diets, but in terms of actual research and scientific studies, there hasn't been any sort of link to a specific type of diet and psoriasis. So a lot of times I tell patients, like, you can try, like certain type of anti-inflammatory diets, or if you feel like there's certain things that exacerbate your psoriasis, then, definitely try and see if eliminating those will improve your skin, but I don't think it's going to cure the psoriasis.
Okay, wonderful. And someone wants to know if there's a link between psoriatic disease and miscarriage.
Yes. So in fact, there has been more studies done on women and around pregnancy, and women who have psoriasis, whether it's arthritis or the skin lesions, do have a slightly higher risk of having miscarriages. So that is true.
Okay. And if a woman is already older, does having psoriasis have a bearing on her projected lifespan?
So that's a hard question. So we do know that there's lots of data coming from Europe that, with a lot of registry studies, that severe psoriasis can affect your lifespan. So severe psoriasis comes with a lot of other comorbidities like I described in the lecture. So that's heart disease and diabetes, hypertension. And so you can imagine with all those other health problems that can affect your lifespan. So it is true that severe psoriasis can affect your not only the quality of your life, but also your lifespan.
Okay, and do you know of any products that are safe for the eyelid, particularly delicate cream that has the potential of entering the eye?
So is that question directed at just routine skincare or treating psoriasis specifically of the eyelid?
Treating psoriasis specifically.
Okay, so definitely. So there are different types of topical steroids or topical creams that you can use safely around the eye, and so I would urge you to talk to your doctor about that. I like to prescribe low potency topical steroids for around the eye, and I tell my patients how long they can use them for. So in general, it's safe to continue using your topical as long as you feel a rough, elevated patch of skin. Patients run into problems when using their topical steroids when the skin is already flat, and really all you're seeing, it may be a little bit of discoloration from the psoriasis, but they find the topical, this topical is working great, I'm just going to keep using it to prevent my psoriasis from coming back, but that's when you run into a problem. So whenever there's an elevated plaque or a rough spot on the skin, that's safe to use your medicine until it resolves.
Okay, great. Someone else wants to know if it's okay to use steroid creams long term.
So it's hard to define long term. So I have patients who are using steroid creams on and off for years. You can consider that long term, but you have to be aware of the side effects and to watch for the side effects. So like I said, with that same question regarding treating the eyelid, because that's a sensitive site, is that as long as you're applying your topical to an elevated thick plaque, usually you're fine. But again, I always talk to, I always give my patient, I always follow up with my patients. I give them the amount of topical creams that I think they should be using appropriately within the right time frame. In sensitive areas like we talked about, the genital area or the folds of the skin, I'm using something much more lower strength, because in those areas you have higher risk for side effects for long-term use of topical steroids. So it's really an individual case-by-case situation. In general, if you're using a topical and you're following instructions from a dermatologist, generally it should be fine. I think in psoriasis, the nature of the plaque is that it's thick, elevated, and scaly. So as long as you're treating the plaque and not your surrounding normal skin, and not treating it when the plaque disappears, in general, it should be fine.
Okay, great. We have a couple participants who said that they notice a flare in their psoriasis around their menstrual cycle and want to know if there's any way to alleviate that.
Very interesting. This kind of links back to the initial question on menopause and psoriasis. There hasn't been a definitely between any sort of hormonal changes and psoriasis, but if you find that, I can imagine that if you have like a lot of menstrual cramping or maybe a heavy menstrual cycle, that may stress your body a little bit and make your psoriasis flare. That might be something you want to talk to your doctor about, maybe going on some sort of birth control to help kind of stabilize your hormones. But there hasn't been a lot of research or any scientific evidence linking hormones with psoriasis.
All right, thank you. And then we have one last question here. Does using natural shampoos help with scalp psoriasis?
So as long as it doesn't cause any sort of allergic reaction. So be careful with natural shampoos, because some of them, in fact, have still have perfumes or or chemicals that can cause, not necessarily chemicals, but ingredients that can cause irritation on the skin. It depends on what type of scalp disease or scalp psoriasis that you have. I encourage patients to use a shampoo that can help get rid of the scale, so it needs to be an anti-dandruff shampoo. And then getting rid of the scale then in turn allows the medicine to penetrate that plaque that's on the scalp in order for the inflammation to decrease in the scalp. So there's not one particular brand or type of shampoo I recommend, but in situations where you have a lot of thick, scaly plaques, then I definitely recommend some sort of anti-dandruff shampoo, and that can be one that's what they call a natural shampoo.
Terrific. Thank you so much, Dr. Song. That concludes our webcast presentation for this evening. If you do have any other questions, you can contact our Patient Navigation Center by phone, email, live chat, or Skype. And once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you complete that and provide your feedback. We want to say thank you again to Taro Pharma for their sponsorship of today's educational webcast and for making this event possible. And I just want to mention before we adjourn, the recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. Thank you, everyone, and have a wonderful evening.